Hello and welcome, fellow student doctors. Today we will discuss antiplatelet drugs. Test makers love pharmacology because it allows them to test the basic sciences in a clinically relevant manner. On that note, I would not focus on clinical indications. That is more of a step 2 kind of thing. Rather, focus your attention on the mechanism of action and side effects of these drugs. Moreover, I developed a schematic to help you organize these high-yield drugs in your mind. Aren't I so thoughtful of you? So, what are we waiting for? Let's go ahead and get started. To prepare you for test day, you will be able to 1. Explain normal ADP receptor and thromboxane A2 receptor signaling, and 2. Explain the mechanism of action and side effects of antiplatelet drugs. Let's start with an overview of signaling pathways. Friends, let me briefly describe the platelet signaling pathways of ADP and thromboxane A2, because, as we will see, all the drugs we will cover interact with these two pathways. So, pictured here are two platelets with one attached to a broken blood vessel through its GP1B receptor, von Willebrand factor, and the blood vessel's exposed subendothelial collagen. This attachment causes the platelet to release ADP and thromboxane A2. Now the signaling fun begins. Let's start with ADP binding to the ADP receptor, also known as the P2Y12 receptor. Once bound, ADP activates a G-inhibitory protein, which we know is named inhibitory because it inhibits the production of CAMP. Now listen very closely. CAMP levels are inversely proportional to platelet activity. Once more, CAMP levels are inversely proportional to platelet activity. So when ADP binds to the ADP receptor and activates a G-inhibitory protein, this decreases CAMP levels within the platelet itself, but it allows the platelet to become more active. Make sure you know this inverse relationship between CAMP concentration and platelet activity. Test makers love to go after it. Okay, G-inhibitory protein activation also leads to the expression of GP2B3A receptors on the platelet surfaces. The GP2B3A receptor is also called the fibrinogen receptor. Why is it also called the fibrinogen receptor? Because this is where fibrinogen binds to start the cross-linking of platelet plug formation. Lastly, as we will see, the drugs we will cover can act here, here, and even here, which are all related to ADP signaling. Clinical medicine is really beautiful when you understand the basic sciences, and you can understand why drug designers chose specific targets within these platelets itself for antiplatelet drugs. Continuing to build on this framework, let's talk about thromboxane A2 signaling, which leads to the activation of a GQ protein, which is related to the IP3 pathway, which induces calcium signaling. Thromboxane A2's actions would take a lecture in and of itself to describe. So, for board purposes, just know that thromboxane A2 leads to platelet signal amplification, which makes sense because calcium is a versatile second messenger and helps granules fuse with the platelet membranes to release various factors onto other platelets, as well as calcium being involved in many other pathways within the platelet itself. Moreover, in terms of drugs, we will study aspirin. Aspirin acts to reduce the synthesis of thromboxane A2. With all of this background in mind, let's start putting some antiplatelet drug names to this framework. Knowing these signaling pathways gave drug designers targets for antiplatelet therapy. Logically, it makes sense to inhibit the ADP or P2Y12 receptor, decreasing all downstream signaling. Ultimately, this would lead to increased CAMP levels and decreased expression of the GP2B3A or fibrinogen receptors. The names of these agents are shown here, with 3 of them sharing the grill in their names, specifically clopidogrel, prasugrel, and ticagrelor. Moreover, ticlopidine and clopidogrel share the clop in their names, as highlighted in red. As for side effects, this class of drugs increases the risk for thrombotic thrombocytopenic purpura, so be on the lookout for the signs of TTP such as thrombocytopenia, microangiopathic hemolytic anemia, AKI, and neurological dysfunction as well as fever. Moreover, ticlopidine specifically has been shown to induce neutropenia in patients, so watch out for answers to side effects of ticlopidine saying medication side effect to account for the patient's neutropenia and subsequent increased risk of infection. Continuing down the path of ADP signaling, drug designers then sought to develop agents to increase CAMP levels within platelets. To know agents that increase CAMP levels in platelets, I introduce you to phosphodiesterase inhibitors, cilostazol and dipyrimidol. Overall, the key to understanding phosphodiesterase inhibitors is to make sure you know that CAMP levels are inversely related to platelet activation. So by increasing CAMP levels within platelets, platelet activation decreases. Again, to do this, these drugs inhibit phosphodiesterase, an enzyme that normally degrades CAMP inside cells. It is important for cells to have phosphodiesterase enzymes degrading CAMP because it is a second messenger involved in a myriad of signaling pathways. Therefore, CAMP levels must be tightly controlled. Before moving on, let's briefly discuss clinical uses and side effects for these agents. While clinical indications are usually lower yield for step 1, one to know for test day is that cilostazol is the drug of choice in treating peripheral arterial disease, marked by symptoms of claudication or tiring and pain with muscle use in the affected extremities. Moreover, test makers will go after the fact that phosphodiesterase inhibitors increase CAMP not only in platelets, but in arterial smooth muscle cells. Listen to this. Increased CAMP levels in arterial smooth muscle cells leads to their relaxation. The relaxation of arterial smooth muscle cells leads to the clinical symptoms of facial flushing, hypotension, abdominal pain, nausea, and headache. Blood vessels are relaxing all over the body, so these vague symptoms actually make sense. Okie dokie, let's now cover GP2B3A antiplatelet drugs. Continuing down our ADP signaling pathway, drug designers then sought to develop agents to inhibit the GP2B3A receptor, better named the fibrinogen receptor. Essentially, these agents kick out fibrinogen and bind to the fibrinogen receptor themselves. Two of these agents are relatively easy to remember, tirofiban and eptifibatide. I say this because of what's highlighted in red. Fib, which stands for fibrinogen, and these agents inhibit the fibrinogen receptor. Sweet! As for abciximab, which is a monoclonal antibody, noted by its MAB ending, I developed a new mnemonic for you. Glanzmann's T. Let the Glanzmann's and Glanzmann's T remind you of Glanzmann's thrombasthenia, which is an autosomal recessive disease in which patients lack the GP2B3A receptor. Also, let the T in Glanzmann's T remind you of the first letter of each of the drugs discussed here. That is, tirofiban, eptifibatide, and abciximab. Not too bad of a mnemonic actually, because you can remember a condition and 3 drugs all together in one place. Why is this important? Well, test makers may say that a patient has Glanzmann's thrombasthenia and then list various antiplatelet drugs and ask you which drug binds to and inhibits the receptor missing from these patients' platelets. Glanzmann's T will see you through. If you do not like this mnemonic, abciximab starts with A and B because it inhibits the 3A to B receptor. In terms of side effects, these agents can cause bleeding and thrombocytopenia, which makes sense as they are antiplatelet agents after all. Now that we have covered drugs targeting components of the ADP signaling pathway, let's turn our attention to aspirin and thromboxane A2 signaling. Essentially, aspirin irreversibly inhibits COX-1 and COX-2 enzymes, decreasing the amount of thromboxane A2. Let me provide some context for aspirin's mechanism of action. So, arachidonic acid is acted upon by COX-1 and COX-2 and thromboxane synthase to produce thromboxane A2. Thromboxane A2 can then signal via autocrine or paracrine mechanisms to amplify the signals for platelet activation. And so, aspirin acts to irreversibly inhibit COX-1 and COX-2 inside platelets, thus decreasing thromboxane A2 synthesis and signaling. Note, aspirin mainly acts on COX-1, which is constitutively expressed, versus COX-2, which is expressed only in times of inflammation. Additionally, see that I highlighted IR in both aspirin and irreversible. You must know that aspirin is an irreversible inhibitor of these enzymes, unlike the reversible NSAIDs like ibuprofen. This point of irreversible inhibition is important because the platelet is thinking, my life is over, and the platelet is correct. Once COX-1 and 2 are irreversibly inhibited by aspirin, that platelet is worthless, and the ability of the body to generate a platelet plug is drastically reduced. So, to recover platelet plug formation ability, brand new platelets must be produced from the bone marrow. Pretty cool, isn't it? Now, let's talk about some of the many side effects of aspirin therapy. First, by irreversibly inhibiting COX-1 and 2, PGE2 is decreased. This can lead to an acute kidney injury since the afferent renal arteriole relies on the production of PGE2 to remain relaxed and patent. Moreover, PGE2 is important for mucosal protection in the stomach, so ulcers are a risk factor for patients receiving aspirin therapy. Next, a board favorite side effect is tinnitus. Research has shown that the metabolic products of aspirin can alter cochlear nerve function in some patients, leading to tinnitus. Additionally, aspirin is associated with allergic reactions such as aspirin-exacerbated respiratory disease, also known as Samter's triad. This is a triad of sinus disease, recurrent nasal polyps, and asthma. Basically, by inhibiting the COX enzymes, more leukotrienes are produced, and in susceptible patients may lead to this triad. Okay, so that was a lot of material. Let's now do a flash quiz to assess your knowledge. The question reads that a patient is suffering from peripheral arterial disease and is prescribed cilostazol. If the CAMP concentration were measured in the patient's platelets and arterial smooth muscle cells, what levels would be expected in each? Take a moment, look through these options. It's a very classic step 1 question. Go ahead and answer it, and then go ahead and proceed to the flip of this card. The answer is B. CAMP levels would be increased in both the patient's platelets and arterial smooth muscle cells. Recall that cilostazol is a phosphodiesterase inhibitor used to increase CAMP levels in platelets, decreasing platelet activity. Remember the inverse relationship. It is extremely high yield. Moreover, phosphodiesterase inhibitors in arterial smooth muscle cells, not the indicated target, lead to increased CAMP levels and arterial smooth muscle cell relaxation. An easy way to think about this is to think that increased CAMP levels relax platelets and relax smooth muscle cells. With all this in mind, let's summarize on the next slide. Thank you for sticking with me throughout this lecture. We covered a lot of material, so let me provide a few key takeaways for each main set of drugs for you to know on test day. First, ADP P2Y12 receptor activation leads to decreased CAMP levels and increased expression of the GP2B3A fibrinogen receptor. Meanwhile, thromboxane A2 receptor activation serves to amplify platelet signaling and activation. Next, clopidogrel, prasugrel, ticagrelor, and ticlopidine inhibit the ADP P2Y12 receptor and can be recognized by grel or clop in their names. Thirdly, it is important to know that CAMP levels are inversely related to platelet activation, hence the use of phosphodiesterase inhibitors, cilostazol and dipyrimidol, which serve to increase CAMP levels inside of platelets and lead to decreased platelet activity. Also, when recalling the GP2B3A receptor inhibitors, use the mnemonic Glanzmann's T to remember the autosomal recessive condition, Glanzmann's thrombocythemia, and the GP2B3A receptor inhibitors, tirofiban, eptifibatide, and abciximab. Lastly, you must know that aspirin irreversibly inhibits COX-1 mainly and COX-2 to decrease thromboxane A2 for the life of the entire platelet. The body literally has to produce new platelets from the bone marrow to regain platelet activity. Isn't that just amazing to you? And so, if you enjoyed the lecture, give it a big old thumbs up and leave a comment, even if it's just to say hello. And always remember, friends, there is a great big beautiful tomorrow.